Hello, my name is Schwarzkopf.
And my name is Andrew Chen. We are research assistants at the Coastal Rare Inflammatory Disease Program based at Dalhousie University and the University of British Columbia. In this video, we will summarize our recent research letter in the Journal of Human Immunity describing two patients who had severe refractory immune neutropenia successfully treated with the oral JAK inhibitor ruxolitinib. The first patient had T-cell large granular lymphocytic leukemia, or T-LGLL. After a successful response to ruxolitinib, our research group decided to repurpose ruxolitinib for a patient with a related disorder, severe chronic idiopathic neutropenia, or severe CIN.
T-LGLL and CIN are among the most common causes of immune neutropenia. T-LGLL disorders are associated with dysregulation in the JAK-STAT pathway and aberrant clonal T cells. The pathophysiology of CIN is less well defined, but is related to a pro-inflammatory bone marrow microenvironment. Treatment options for T-LGLL include immunosuppressive agents such as cyclophosphamide and methotrexate. Treatment of CIN is typically used with granulocyte colony stimulating factor, or G-CSF. The first patient was a 68-year-old male who presented with febrile neutropenia in 2009 and was found to have T-LGLL. Over the next 13 years, he had several therapies including G-CSF, corticosteroids, splenectomy, oral cyclophosphamide, cyclosporin, methotrexate, and azathioprine, all of which were ineffective. His neutrophils remained less than 0.3 billion per liter, and he had recurrent bacterial infections. In June 2022, he was started on ruxolitinib, dosed at 5 milligrams twice a day. His neutrophils increased to greater than 2 billion per liter within 1 week of starting ruxolitinib and have remained normal for over 3 years.
The second patient was a 77-year-old male who presented in October 2023 with severe neutropenia. His peripheral blood smear showed marked neutropenia, and bone marrow biopsy showed a relative decrease in mature neutrophils consistent with CIN. Over the next 10 months, his neutrophils were less than 0.3 billion per liter, and he had several bacterial infections. He was given methotrexate, cyclosporin, cyclophosphamide, and mycophenolate in combination with low-dose prednisone and G-CSF, none of which resulted in an improvement. In February 2025, he began ruxolitinib, and once he reached a dose of 20 milligrams twice a day, his neutrophils increased to more than 1.5 billion per liter.
These cases demonstrate the efficacy of ruxolitinib to treat severe immune-mediated neutropenia. Ruxolitinib is an emerging therapy in T-LGLL and can even work in very refractory cases. Given the diverse immunomodulatory effects of JAK inhibition, we postulated that ruxolitinib would also be beneficial in severe CIN.
To our knowledge, this is one of the first new therapies reported for severe CIN in over 25 years, and an important real-world example of drug repurposing in rare disease. Thank you for your attention.